Well, good evening. I'm Dr. Jeff Schaefer, and I'm the co-chair along with Maria Hernandez of the Sleep Committee for the American Academy of Orofacial Pain. And both Maria and I will be panelists tonight in our first presentation in our sleep apnea lecture series. I'm really glad that everybody signed up. We've got good attendance tonight, so we're excited about that. This is a sleep apnea series that we decided to do for the year 2023 to 2024. And rather than having a 1 day or 1 day and a half sleep apnea conference in conjunction with the mid-year meeting of our AAOP council, we decided to do a lecture series throughout the year. We'll have 5 lectures for this year, and then some other ones starting next fall. And it'd be interesting to get our feedback from our members as to what they like best, if they like having a 1 day conference versus a lecture series. But this is our first webinar on sleep apnea. Very excited about it. We have a great speaker. Dr. Noah Siegel is an otolaryngologist at Mass Eye and Ear Infirmary, which is a Harvard Medical Teaching Hospital. He's actually interesting reading through his CV. He was the first otolaryngologist in Massachusetts to be board certified in sleep. He's the medical director of the Mass Eye and Ear Department of Otolaryngology. As I said, that's a Harvard Medical part of Harvard Medical School. He's been involved teaching orofacial pain residents both at Mass General Hospital and at Tufts University. And he's also been involved with teaching sleep at the Harvard School of Dental Medicine to undergrad students. So he's very tied into the dental role in sleep apnea. So I'm really happy that he's willing to present to us today. He's also the director of the Sleep Medicine and Surgery Division of the Mass Eye and Ear Infirmary. So he's going to talk a little bit about some of the surgery options that are available to our sleep apnea patients, especially if they don't do well with other treatments. He got his college degree and his MD from the University of Michigan, and he completed his general surgery internship at Northwestern Medical School. His ENT residency was done at Harvard Medical School. He's board certified in otolaryngology and sleep medicine. And tonight he's going to enlighten us on how to do an evaluation of our sleep apnea patients from an ENT perspective. So Noah, here you go.
All right. Well, thank you so much for having me, Dr. Schaefer and Dr. Hernandez. Before I share my slides, just a few notes or a few comments, and that is I've really enjoyed working with dentists over the past 15 or 20 years in the realm of sleep. I think there's a lot of commonalities. Our 2 fields both offer non-CPAP options for obstructive sleep apnea. And we're also very much sort of anatomically focused. We spend our time looking at the airway, touching the airway, manipulating the airway. So I think our 2 fields, particularly working together, can achieve great things. And if I could, actually, when you get some gray hair, you get to give the past, present, and future of sleep medicine talk. So I gave one recently, and one of my future things was the involvement of the dental community heavily in the management of sleep apnea. And it includes unquestionably pediatric dentists, unquestionably orthodontics, unquestionably those that fabricate mandibular advancement devices and so-called dental sleep medicine, as well as oral surgeons. So that is unquestionably and absolutely the future. So I really enjoy collaborating with the dentists. And I've learned a lot from your community, and hopefully I can share a little bit of what I've learned to you guys, both tonight and then potentially beyond. So let me go ahead and share my screen. So tonight I'm going to walk you through how an otolaryngologist approaches the airway. So before I kind of get too heavily into that, I want to make an important comment, and that is, although I am an otolaryngologist that does both sleep medicine and sleep surgery, the majority of this is really pretty straightforward otolaryngology. I mean, this is what we do. That we're all trained to do this. We're all comfortable kind of looking at manipulating the airway and putting in scopes. So although, again, I mean, be bored and have an academic position and, do sleep medicine as well, this really is reasonably straightforward. You don't need to necessarily find somebody like me in your communities. Most otolaryngologists would be very comfortable with this. So why don't we just sort of jump right into it? I'm going to state the obvious and say that obstructive sleep apnea is a syndrome of respiratory disturbance due to upper airway obstruction. Can you guys see my cursor here? Moving around?
Yes, we can see
Okay,
it.
great. Thank you. So this is to state the obvious, and it's so obvious to us as healthcare providers that spend their time looking at the airway. It's not that obvious to many fields. In fact, many of the fields that manage sleep apnea don't really have a great understanding of the upper airways. But to me, this is kind of fundamental. It leads to the question is who should get an airway examination? To me, in an ideal world, the answer is everybody. If the problem is upper airway obstruction, shouldn't everybody have their upper airway examined at some level, right? If somebody has a cardiac issue, we're going to examine the heart. Why necessarily would this be any different? So again, in an ideal world, as perhaps a little bit on my soapbox, as somebody that spends time looking at the airway, everybody should have it, but that's probably not realistic. So where would I kind of draw the line? I would say, perhaps some individuals, certainly children, where adenotonsillectomy is still commonly considered first-line treatment. Those that have upper airway symptoms. So, for example, if somebody were to have swallowing issues or voice changes, there could be something else going on, which is narrowing the airway. You all understand that. Individuals with craniofacial anomalies. If their obstructive sleep apnea is substantially out of proportion to their body weight. So, for example, I think you could probably get a sense that I'm reasonably thin. If you saw somebody like me and they had really severe apnea, you kind of wonder, well, like what's going on in there? So perhaps they should have an upper airway examination. And then certainly, if we're considering alternatives to CPAP therapy, if they can't use CPAP or if they're unwilling to tolerate CPAP, and we're looking at alternative treatment options, why certainly we need to assess the airway. So these are some of the faces of upper airway obstruction. So in the top left, obviously, there's an individual with markedly enlarged tonsils. That's kind of an obvious one. That's what you see why their airway is obstructed. In the middle, we see a woman with severe retrognathia. So y'all doing what you do understand why that's an airway issue. We can have mid-phase hypoplasia. Here's a child with probable nasal obstruction, perhaps enlarged adenoids. And on the bottom left, we see a woman that's markedly obese. So these are all obstructive. These are all individuals with crummy airways, but they're crummy for different reasons. And I'll carry that one step further. So if you all were otolaryngologists and you looked at this, you'd say, oh yeah, there's a lesion in the vallecula, right? There's the epiglottis, there's the base of tongue. Here's somebody with really severe inflamed larynx. These are their vocal cords, really severe, what we call polypoid chorditis, and a little cyst in the vallecula. Laryngomalacia, that's the epiglottis. You can barely see the larynx, some nasal valve collapse, some severe nasal polyposis, and a base of tongue tumor. These are also people that have airway obstruction. So how do we treat the airway? Right? What I like to say to my patients is if somebody has upper airway obstruction, how do we treat it? We open the airway. Duh. Right? So, and how do we do that? We can do that in lots of different ways, right? We can blow air into it, which is what CPAP does. We can advance the mandible, essentially, in very simplistic terms, do a jaw thrust, right, to help expand the airway. We can make the hole bigger by coring out some of the tissue, right? There are other devices on the market like Provent, which we're probably not going to talk much about, positional therapy, weight loss therapy, and we're going to talk later on about hypoglossal nerve stimulation as well. So if an otolaryngologist is seeing a sleep apnea patient, very likely they're talking about surgery. So before anyone's considered for something surgical, these are some of the questions that we would want to ask. Is the patient tolerating CPAP or oral appliance therapy? And the answer is yes, we're probably done. What's the severity of their apnea? What's their level of obstruction? What's going on with their anatomy, right? What are the patient's comorbidities? We may have somebody with moderate or severe sleep apnea, but they've got congestive heart failure, or they're on blood thinners. We're probably not going to want to touch that individual. If a person has unrealistic expectations, which, by the way, most of them do, they think that, hey, surgery is the fix, and in many instances, it just isn't. There are very significant perioperative anesthetic considerations. Remember that these are people often with undiagnosed cardiovascular comorbidities. By definition, they have crummy airways, right? That's why they're seeing us, because they have obstructive sleep apnea. They don't breathe well. And what do we do in surgery? We intubate the airway. We manipulate the airway. We give them narcotics. We give them sedatives. That's the recipe for a problem. So we need to be really careful around the time of surgery. So what's going on in the management of sleep apnea from a surgical perspective? We're trying to be less destructive. We're trying to better identify what's going on, and that's what I refer to as the level and pattern of obstruction. And we're going to talk about DISE, that stands for drug-induced sleep endoscopy. And in the end, it's really all about patient selection. We've all heard the term. Well, we've all heard people say, "Well, surgery just doesn't work," and I think that's a little bit of a simplistic approach. But there's good reason for that. In the end, and the reason people have that impression is a lot of people for a lot of years either shouldn't have had surgery or got the wrong surgery. We're also looking at surgical therapies not necessarily as being curative, perhaps maybe adjuvant. If I can improve somebody's nasal airway patency, they may do better with an oral appliance, or they may do better with positional therapy or weight loss therapy or CPAP therapy. And then we'll talk about hypoglossal nerve stimulation. So a couple more kind of general comments on sleep apnea. Is generally not considered first-line treatment. And the procedures that we do really depend on what's going on with the airway, right? Duh. It's all about patient selection. We'll kind of go through these as we talk. So here's sort of here is a sagittal view of the airway. And every patient we look at, this is essentially how we assess the airway. We're looking at all components of the airway, including the nasal cavity. I'll be talking about the nose quite a bit at the end. And one other headline of what's going on in sleep these days is that it's much more than just anatomy. All right, there's physiology. So this is a little bit of an aside, but what's going on in sleep research right now is an approach to what we're calling endotyping or phenotyping, where each individual has a little bit of a unique physiology, right? A unique physiology. And components of the physiology may be how they respond to drops in their oxygen or their CO2 level, their arousal threshold, their muscle responsiveness. And these are individual characteristics that can also help guide treatment. It's not just anatomy. Okay, headline. We're going to look back at the way we treated it, the way we're currently treating people, and say, well, that was really simplistic. We really weren't including physiology, but that's a lot of the future of sleep medicine, which is looking at individual physiologies. And the terms that you're going to hear are called endotyping or phenotyping. So there's a lot of good papers that are out there. And if you go to any lecture, any sort of, let's say, course on sleep apnea, they're going to talk quite a bit about this, and that's where the field is heading. So again, that's a little bit of an aside. So we look at the airway, just like you guys look at the airway. We look at the airway, probably with gloves and some sort of light source here, but you get the idea. In the office, we often use a fiber optic scope, right? So we're kind of get an internal view of the airway, right? We're not seeing what's going on with the muscle, but we're seeing what's going on internally. And then probably the biggest change in how an otolaryngologist is going to approach a patient with sleep apnea is through a newer approach, which we call drug-induced sleep endoscopy. So in short, we call it DISE, right? So the idea there is, well, the headline here is an office examination takes place with a person upright, awake, with muscle tone. Right, but okay, everyone hopefully that's listening to this right now is upright, awake, with muscle tone, and you know what? You're breathing just fine. So why is that our office examination? So what we do is we try to replicate what's going on during sleep. So we bring them to the operating room, and we put them to sleep, right? And I do sleep with air quotes because they're not technically asleep; they're sedated. They're pharmacologically asleep, and the primary drug we use is propofol. So while that individual is asleep, we then get a look at the airway. And the idea behind that is to sort of figure out what procedure to do or to analyze surgical failures. If somebody were to do a surgery and they're still having, significant sleep apnea, you'll look and see what's going on. So hopefully this will play. So here's what I'm going to show you right now is a video. Hopefully you'll have sound. Do you guys have sound?
No, we don't.
Right, so I'll narrate. So what you're looking at right here is this is an individual that you don't see the patient. They're down here, but he has a scope into the patient's airway, and they're looking at a screen. Maybe not great ergonomics, kind of looking back over his shoulder, but that scope right now is in the nasal pharynx, right? And if you could hear this, you'd hear snoring. You see fluttering motion of the soft palate, right? There's the posterior pharyngeal wall, right side, left side, back of the soft palate, so there's some snoring. In a second, he's going to advance the scope, and you're going to see what's going on with this person's airway. So you're going to see major collapse from both sides. Watch here. So the two sides collapse in. See, he did it with his finger. So what you're seeing is big tonsils narrowing the airway. Airway's obstructed, airway's open, right? So what's coming in from the lateral, and what's lateral? Those are prominent tonsils. That's what you're seeing right there. So that's an example of what we might do. Here's another example of airway obstruction. So what you're looking at right here is hypopharyngeal level. So here's our epiglottis, here's our base of tongue, and you can see somebody's airway is narrowing, right? So here's a base of tongue problem. Before we saw tonsils, but this is a different problem. Watch, we're going to see somebody have a pretty, and I'm going to advance it just to save a little bit of time. But say, so here's an obstructive apnea. That person is not breathing, minimal airflow, right? O2 sats are dropping, and then in a minute, so long apnea, still not breathing, not breathing, not breathing, not breathing. And then you're going to see an arousal and the airway is going to open. So sats are dropping, and here's our arousal. Airway's open, right? So you get some muscle tone back to the tongue. So I'm going to jump ahead. Here you're going to see some obstruction at the level of the soft palate. That was base of tongue. You know, again, here's where tonsils would be, and you're going to see more level at the level of the nasal pharynx, so what we call the velopharynx. Oops. Sorry, just jump ahead there. Also base of tongue obstruction. You know, to make the point, it's oftentimes multiple levels of obstruction. So we saw one like this before. Here you're going to see big tonsils from either side, right? See the tonsils coming together, obstructing the airway. We'll go to one more. We saw tongue base collapse before. This is also. So you can see that at this individual, here's our epiglottis, here's our base of tongue. And I'm going to, just in the interest of time, move through. And then also we can have obstruction at the level of the epiglottis. So here you can see the epiglottis is flipped posteriorly, right? Obstructing the airway. This is somebody that actually may struggle with CPAP. If you blow air into an individual's airway and the epiglottis flips back, they're not going to be happy. And then I'm going to show you kind of a funny pattern of kind of epiglottic obstruction. So if that, you know, again, very different. It's not flipping back and forth, but it's also almost kind of squeezing down. That's epiglottic collapse. But again, you can see that there are different patterns. The headline that I want to make, what I want you all to remember, is that what we looked at are all very different, right? We saw somebody with big tonsils. We saw somebody with base of tongue obstruction. We saw weird epiglottic stuff. We saw soft palate stuff. So anyway, the point of all of this is that when we look at the airway, that helps guide our surgical therapy. So that's really kind of the main innovation that's taken place. So remember the whole obstructive sleep apnea surgery does not work, right? Well, in 1996, an otolaryngologist named Aaron Scher published this paper, and in the abstract, analysis of UPP papers reveal that this procedure is at best effective in treating less than 50% of patients with OSA, right? And remember, to me, the most interesting thing about this, less than 50%, and these are the people that publish their data, right? Remember all the people, like if you get bad results, you may not be publishing, but these are the people that publish their data. So essentially what came out of this, and the answer is it was actually probably closer to 40% that were effective, is that, you know, quote unquote surgery doesn't work, and that sort of stuck, right? A lot of people are getting UPPs. But if we take that same paper and we look at it in a little bit more detail, stick with me on this. So a UPPP is an oropharyngeal obstruction. So if a person has obstruction at the oropharyngeal level and they get surgery, their numbers are better than if they have an oropharyngeal procedure but have hypopharyngeal obstruction. These patients got the wrong surgery, right? So where was the obstruction? If they got the right surgery for the right level of obstruction, their numbers are better. It also depends on how you define success, right? The more stringently you define success, the worse your results are. But if you had a fairly low threshold for defining success, just a 50% decrease in the apnea index, you did reasonably well, right? If you were more stringent, your numbers weren't quite as good. Anyway, you get the idea. And I'm going to keep coming back to that component, or to that comment, which is it really has to do with the level of obstruction. So this is what y'all are used to kind of hearing about UPPP. This is the historic, what we call Fujita UPP. Take out the tonsils, trim the portion of the soft palate, including the uvula, and stitch it up. Right, so that's kind of the classic UPP. There's other variations. What you see right here in the top right is called an expansion pharyngoplasty, or expansion sphincter pharyngoplasty. This is the most commonly performed procedure now. We take out the tonsils, you incise the palatopharyngeus muscle, you create a little sling, we sort of suture it superiorly and laterally to help kind of keep the airway open. Anyway, there's multiple different procedures, but this is the most common one that's performed these days. And obviously tonsillectomy. Tonsillectomy is a great option. Here's a postoperative result. Probably better. Here's a bad outcome. Here's a lot of scarring. Remember, if you have all that raw tissue in the back of the pharynx, you can get circumferential scarring and stenosis. This person has a really lousy airway, and they don't breathe well through their nose either. And clearly, this is an individual who had a fairly prominent tongue. So, here's a study, and this kind of makes a point, which is, boy, you're really desperate when your randomized controlled trial is UPP versus nothing, right? So 65 patients, UPP versus nothing. The outcome was AHI reduction. Hey, pretty good. Our UPP did better than nothing, right? So about a 60% decrease. Interestingly, there was 11% decrease in the controls, and it was statistically significant. Congratulations, surgeons, right? You're better than nothing. But what's interesting is the quality of life improvement was also quite good. And you're going to see that in a lot of the studies that we mentioned, that people have a very nice improvement in the quality of life with some of these surgical procedures. And I'm going to highlight that as we talk about it. So this is, remember I talked about expansion sphincter pharyngoplasty as being a new treatment. So here's a study that just looked at outcomes comparing the two. You guys will have all these studies, so I don't really need to talk to you about it with the references as well. So tonsillectomy, we talk about it as a primary treatment in children, but in adults, it's a fantastic treatment. If we see an individual with big, giant tonsils that are just touching, just get the tonsils out, right? Adult tonsillectomies are miserable. They hurt like crazy. They need narcotics. There's risk of bleeding, but they work really well. So here's an example of the AHI pre and post-op. In 28 patients, the average pre-op was approximately 40. The average post-op was around 5, and a nice improvement in the Epworth Sleepiness Score. Oh, I didn't mention what Epworth Sleepiness Score is. That's a kind of a measure of sleepiness. If you don't know, it asks that there's a series of 8 questions that says how likely are you to fall asleep in these various scenarios. And there's 8 questions, and you answer 0 through 3. The maximum score is 24. Anything greater than 10 is considered abnormally sleepy. So there's also other procedures, soft tissue procedures that take place at the back of tongue. I'm going to leave, this is more skeletal, obviously. You're really not going to see many genuglossal advancements. You're really not going to see many partial glossectomies or radiofrequency reductions. But these are also tissue reductions, soft palate, and the airway. We don't see many of these because hypoglossal nerve stimulation has really taken over. There are different ways to do it. If you look at the sagittal MRI scan, you can see this individual has really prominent base of tongue, lingual tonsillar tissue. You can see here on an endoscopic view, so a realistic or a consideration could be radiofrequency removal of that tissue, or perhaps robotic surgery where you get a really good visualization at the base of tongue. So you may hear about transoral robotic surgery. It's done a little bit. It's kind of fallen out of favor lately because of hypoglossal nerve stimulation. a lot less morbid approach and probably more effective. So here's a picture of that. So tongue surgery meta-analysis looking at the studies. So here's a meta-analysis of over 500 patients. The majority of them got multi-level surgery, right? So remember, so this is where it gets muddy, right? They're getting surgery at probably the soft palate and the base of tongue, and only 24 out of those 500 or so patients had isolated tongue-based surgery, and indeed they got better. So even with this very aggressive surgery, the mean post-op is still in the moderate range. So a nice reduction, more than 50% reduction, a nice improvement in Epworth Sleepiness Score, and a nice a nice increase in the minimum O2 saturation. But hey, do not underestimate the morbidity of these operations. They hurt. And remember, we talked about earlier the perioperative concerns. Like, you need to watch these individuals' airway. You have to be very careful with perioperative narcotics. Bleeding is a big deal. Okay, so skeletal surgery, I'm talking to a bunch of dentists and probably some oral surgeons. Skeletal surgery, particularly MMA, is an excellent treatment. I include genoglossal advancement. There's something also called a transpalatal advancement, where you remove a portion of the hard palate at the junction of the soft palate, and then you sort of essentially move the soft palate forward. Risk of fistulization, you're not going to see that very often, but MMA is an aggressive but highly effective treatment. There's also something that you'll probably hear more about. You all are used to seeing people with very narrow, high palates, kind of more of a vertically oriented airway. You could do osteotomies, Lefort osteotomies, as well as a midline osteotomy, and expand the midface, right? Just like you might in a kid before the sutures form. Obviously, you're going to end up with a big gap in the front teeth and potentially some occlusive issues, which is why you really need to have your orthodontics involved. But over time, I think we're going to be seeing more of these midface expansions in adults. And we see these, and you see these patients all the time. People with these super narrow mid-faces, very vertically oriented, maybe had their premolars extracted many years ago, that these days would have had mid-face expansion, probably RMA as children. So MMA results are excellent, really excellent. You have a very nice reduction in the severity of the sleep apnea, but it's a pretty aggressive operation. It's going to change the appearance of the face. You risk some numbness in the mental area, but you can have a very reasonable cure rate. In an experienced surgeon with well-selected patients, outcomes can be absolutely excellent. All right, so let's talk a little bit about upper airway stimulation. You all have heard a little bit more about hypoglossal nerve stimulation. The way that it works is that there's an implantable device. We're going to call it impulse generator. It's inserted in the right upper chest, opposite where a pacemaker would be, so the right upper chest. There is a lead which interdigitates between the intercostal muscles, which is down here. Normally, these are done with just one incision here and one incision in the submandibular region. And then a cuff is wrapped around the distal end of the hypoglossal nerve. So what will happen is this is a different device, but it shows it pretty well. This device is not on the market. The only FDA-approved device in the U.S. right now is Inspire. So there's a respiratory sensor lead, and then one that dips around the muscles of the tongue, which stiffen and protrude the tongue to help protect the airway. It's FDA approved based on a study completed published in 2014, where, as you can see, there's a very nice reduction in the severity of the sleep apnea from an AHI of 29.3 down to an AHI of 9, a 68% reduction. Oxygen parameters also improved. Epworth Sleepiness Score and functional outcome of sleep quality also improved in these individuals. Limited adverse effects. And then we're having, again, this is the same thing. We have pretty good data now that these patients were done in 2014, so we're coming up on 10 years, and the majority of the patients are still using it. In the long-term data, most recent published was 7 years, where most patients are still using their devices and are achieving benefit. One thing to note, at 10 years, the battery needs to be changed out, so patients are going to start needing battery changes. Here's the 5-year outcome. So who were the patients? So these are adults, 22 and over. They have moderate to severe sleep apnea. The typical parameters are an AHI of 15 to 65. They need to have either can't or won't use CPAP, By the way, we sometimes will go over 65 AHI because we don't really have many other great options in many of these patients. They can't be terribly overweight. Some insurances will allow up to a BMI of 35. And obviously, the vast majority of their events need to be obstructive. We don't do this for central apnea. We do it for obstructive indications. And in addition to that, all of these patients need to undergo drug-induced sleep endoscopy. There's one particular pattern on drug-induced sleep endoscopy, which is called complete concentric collapse, which is thought to predict for poor results with hypoglossal nerve stimulation. So I got to tell you, when I first heard about this treatment option, I'm like, no way. Who is going to go for this thing implanted in their chest that stimulates the tongue literally every breath they take during sleep indefinitely? Well, I just couldn't have been more wrong. So many people, it's a great option for people with moderate to severe sleep apnea. It's not as effective across the board as CPAP, but way better tolerated. And I also thought, well, aren't people going to be bothered by the electrical stimulation to the tongue with each breath? And the answer is really not so much. And by the way, there are oral surgeons that are doing these, and certainly oral surgeons know, great surgeons know their way around the submandibular region and easily can make a chest incision and implant one of these things. But I also want to make the point that it's much more than just the implantation procedure. It's managing the device indefinitely, and there's a lot of nuance to that very likely involves the input of a sleep medicine doctor. Bariatric surgery, hey, great option as well. We know that as weight goes up, the likelihood of sleep apnea goes up. So, here's a good example of the impact that bariatric surgery can have. Mean age is 44. AHI with bariatric surgery goes from 54 down to 15. BMI, also a significant improvement. As you might imagine, better results in younger and lighter patients. And this is also kind of a little bit of humble pie for the airway surgeon, right? Patients do better with weight loss surgery than they do with airway surgery. So what does that tell you? Hey, it's a weight problem. And then, if you ask any ear, nose, and throat doctor to talk, you can bet he or she's going to talk about the nose. So I'm going to talk about the nose. Indulge me for about 10 or 15 minutes or so, and we'll have time for questions. So let's talk a little bit about the nose. But before I begin kind of diving in, I'm going to ask you a few questions that I want you just to kind of answer in your own mind. Does nasal obstruction cause sleep apnea? Just think about the answer to yourself. Can treating nasal obstruction improve sleep apnea? Can it improve CPAP compliance or oral appliance use? And can treating nasal obstruction decrease CPAP pressure? So I want you to kind of think about those. So the nasal airway. So why do we have this hole? Like, what's it do? One, it's a conduit for airflow. Our nose warms, humidifies, and filters the air that we breathe. There's a resonance chamber for our voice, and also it's where the olfactory nerves kind of emanate from the anterior cranial fossa down into the nasal cavity. So the nose is also involved in olfaction. My dog is being very patient over here. So nasal airway system. So we're talking about upper airway obstruction, right? We're talking about upper airway obstruction. And to me, it's amazing that the majority of, or the narrowest part of the airway is right here, right in the front part of the nose, right? It will account for many people up to 50% of the airway resistance. It's the smallest sort of part of the airway. And this gets a little bit tricky, but all I want to make it to call attention to is Q is flow and R is radius to the fourth out power. So by very small changes in the radius of a conduit can have marked changes in the amount of airflow. So little changes right here at the narrowest part of the airway can impact flow dramatically, right? That's all I wanted to say. This also gets a little bit confusing. We can think of the nose as kind of semi-rigid, although it is somewhat dynamic. And then the trachea is somewhat rigid, right? So nasal here, tracheal segment here. And there's a bunch of floppy stuff in the middle, right? Tongue, soft palate, pharyngeal walls, tonsils, right? All of that's floppy stuff in the middle. If you have negative pressure here, all that floppy stuff is going to narrow, right? So you get negative pressure from here that gets transmitted down to the lower airway. So in that, what I'm going to call the oropharyngeal or the collapsible segment of the airway. So examine the nose. Crooked noses, lesions externally. That just by looking at this guy's nose, it's crooked. It'll likely be crooked on the inside. Here's somebody that has a saddle nose deformity, probably traumatic. Example of nasal valve collapse. So any of us, if you breathe in quick enough, can get valve collapse, right? Remember Bernoulli's principle. Y'all are looking in the mouth. If you just look up a little bit, you'll be able to see. You'd be surprised at what you can see. Here's an example of that most anterior caudal aspect of the septum deviating into the patient's left nasal vestibule. That's pre-op. That's post-op. Here's a pre-op, post-op. Or again, same thing where that caudal aspect is emanating or kind of extruding into the nasal vestibule. We like to talk about the nasal valves. This part here, that concave area, we call the internal nasal valve. It's underneath the upper lateral cartilage. And then the external nasal valve is essentially the ala, or we call these the scroll cartilages. So there's the internal and external, and people can have collapse in either. If you look inside the nose, there's what we call kind of the internal valve angle. Here's the septum, here are the turbinates. If you look inside, this can be narrowed because of collapse of the nasal valve or deviation of the septum. Here's an example of somebody, breathing in, and you can sort of see collapse of the airway there. I don't think you're hearing audio, but basically what's happening there is somebody's having collapse of both the internal nasal valve and the external nasal valve. Now, here's the crazy part about it, is you say, well, which side does this patient not breathe through? The answer is his left side. Limited airflow here, but then the air flowing through the right side causes a valve collapse, right? Bernoulli's principle. So that's what that is. So we'll skip that. Anyway, y'all feel free to look in the nose if you're working with otolaryngologists and you identify a patient with nasal obstruction, a nasal valve collapse. These are patients that, just about any otolaryngologist can easily manage. If you do decide to look up into the nose, septum's here, inferior turbinate is here. You don't really see it here, but the middle turbinate is going to be a little bit more posterior and higher in the nose. This is the undersurface of the upper lateral cartilage, and that's that internal nasal valve. So another way you can look at valve collapse is if you do it right now, and you just push the lateral aspect of your nasal slide wall in your face. If you just push it laterally, that's going to open the nose. That's what those nasal dilators will do, is what we call a caudal maneuver. And if somebody has a positive caudal maneuver, it means that when you do that, they breathe better. Most people are going to breathe better, but it can be indicative of nasal valve collapse. So here's another example of nasal valve collapse, or a couple more examples of it. Turbinates also take up a fair amount of space in the nose. Here's somebody, what you're looking at there is their septum going towards the right side. You don't really see their inferior turbinate very well. Here's nasal septum. Here's an inferior turbinate, which is not terribly swollen, caudal deviation. Anyway, what kind of ENT talk would this be if I didn't show you a bunch of gross, pictures from inside the nose? So again, nasal septal deviations. And I like to sort of double click a little bit on turbinates. So what are turbinates? Turbinates, as you all know, are these tubular structures that live in the lateral wall of the nose. So the septum's in the midline, the turbinates front to back. And the key point here is turbinates are dynamic. Why is it? Same guy, same nose? Why can I breathe sometimes and other times I can't, right? Like, what's going on in there? The answer is the tissues are changing, primarily the turbinates. And the turbinates will respond to lots of things: a cold, allergies, chemical exposure, temperature changes, hormonal fluctuations, body position. That's a big one. People will tell you they lay down at night and their nose blocks up. Oftentimes it's the more dependent side. And the nose also has something called the nasal cycle, where it's fluctuating from side to side. Here's an example of somebody whose right inferior turbinate is swollen. Left one isn't. This may alternate from side to side with the nasal cycle. So again, swollen mucosal surfaces. People also can have nasal polyps in the nose, which we're always looking for. Here's an example of a clear nasal cavity. That's kind of normal. Here's somebody whose nose is kind of chock full of polyps. They can also have prominent adenoids, tend to be more in children. Obviously you can see this as a child. So that may be another culprit with respect to nasal obstruction. Here's an endoscopic view of enlarged adenoids. Here's the septum. Here's the posterior aspect of the left inferior turbinate. What you're looking at there is prominent adenoids. Nasal obstruction is related to obstructive sleep apnea, right? Or snoring. There seems to be a clear relationship. I don't need to go through all of this. You can look at it. You have the slides. This is probably my favorite slide to talk about. So basically, we looked at, or this particular researcher back in 2003 published a study where we looked at airway resistance nasal versus oral breathing. So higher the resistance, the worse the airflow, right? There's resistance to airflow, right? So during sleep, with the mouth open, airway resistance was almost double that of nasal airway resistance. So let me restate that. With the mouth closed, breathing through the nose, substantially less airway resistance. And that's exactly counterintuitive to what you'd think. You'd think if you breathe through a bigger hole, your mouth, you're going to have lower air resistance. It's the exact opposite during sleep. The exact opposite during sleep. This is from that same study where those patients with their mouth open versus nasal breathing, there was a very marked reduction in the severity of their apnea-hypopnea index, or the severity of their sleep apnea. So what do? We treat allergies, we control environmental factors, we sometimes perform surgical procedures with the intention of improving their nasal airway, helping with their snoring, hopefully helping with CPAP or oral appliance. What do? The turbinate, all kinds of stuff. We crush it, we cook it, we remove bone, we partially excise it. We use radio frequency or electrocautery. Anyway, whatever we do, we kind of beat up the turbinates. You don't want to beat them up too bad because then you don't get the warming, humidifying, and filtering the air functions that we talked about earlier. And people ask you, I don't want to get empty nose syndrome. Very unlikely to happen unless you essentially chop out the whole, turbinate. So here's an example of a radio frequency reduction. Here's the septum, here's the turbinate. You use one of these little wands. You put it submucosally after you numb the nose. We do this in the office all the time. We repair deviated septums. We remove nasal polyps. Here's an example. This is kind of fun to look at. So you remove nasal polyps. Here's somebody that is going to have a big old polyp pulled out of their nose. And this, as you might imagine, would help them breathe better. Again, what kind of ENT talk would this be if I didn't show you some gross videos? So we repair nasal valves. I like to simplify saying, well, remember, we looked at this video. If the nasal airway is narrow, we widen it. We do things like spreader grafts. If it's floppy, we stiffen it. So there are all different ways that you can do that. You can do it externally by dilating it, either a nasal strip or an intranasal dilator, or we can do it surgically by putting in what we call spreader grafts or batten grafts or some sort of tip stabilization work. There's also implantable devices that can be used to help stabilize the nasal airway. We take out adenoids. I'm going to skip that. So one study, I believe that many of you probably do oral appliance therapy. So with oral appliance therapy, there's a study that looked at nasal resistance, the impact of nasal resistance on response to oral appliance therapy. There are not a lot of good studies out there on this. This is a fairly old study, only 38 patients. But these are complete response, no response. And the complete responders had lower nasal airway resistance. And if you talk to a lot of experienced dental sleep medicine providers, they'll tell you that their patients that do better with nasal breathing tend to respond better. Again, I don't want to overstate that, but it's not an uncommon finding. But we don't have great studies on that. So how about just nasal surgery and overall sleep quality? Sleep quality, I'm not talking about sleep apnea. So if a patient has nasal obstruction, what happens to their sleep quality? Sleep quality index improves, and their Epworth sleepiness score, their level of sleepiness. Again, I'm not even talking about sleep apnea here. Just people like to breathe through the nose. And I'll throw this back at all of you. When your nose is stuffy and you have a cold, you're not sleeping well, are you? Right? And what's happening is you're probably snoring more. What we see on sleep studies is that people are having sort of airflow restriction and what we call microarousal. So they're waking up, kind of mini awakenings over the course of the night. So just plain old nasal surgery. And a lot of times people come in not so much for sleep apnea at all, but just they want to breathe better through nose. People like to breathe through their nose. So how about isolated nasal surgery and sleep apnea? I'm going to kind of go to the second study, which is this one. So this is the best meta-analysis that's out there. It was 18 studies of patients. So stick with me. Isolated nasal surgery in patients with obstructive sleep apnea. Remember, we're not doing pharyngeal surgery. We're not doing tonsillectomy, nothing to the base of the tongue, just nasal surgery in patients with sleep apnea. What happened? Here are the studies. You can see that, the size. Basically, the AHI, here's the improvement in the AHI. What we're looking at here is a forest plot, an overall improvement in the AHI and an overall improvement in sleepiness. So what does this study show? That AHI and Epworth sleepiness scores significantly improved with isolated nasal surgery. And that supports the role for isolated nasal surgery in carefully selected patients. Now, here's the key point here. It's hard to predict who are the people that are going to do really well with this. Now, I want to be clear. When I talk to my patients, I will not say to them, if I fix your nose, I'm going to fix your sleep apnea. I will say to them, if I fix your nose, it's because you want to breathe better through your nose. And oh, by the way, if your snoring and sleep apnea gets better, rock on, icing on the cake. But that's not why we do it. We do it to help them breathe better through the nose. But the studies do demonstrate that there's a subset of people that tend to do well. Now, there's some things that we try to do to help better, stack the deck towards improved outcomes with respect to sleep. But again, our indications for nasal surgery is really not to improve the degree of sleep apnea, although it can help in some people. So I know I'm kind of phrasing it carefully. So how about nasal obstruction and CPAP? So if y'all are seeing patients with sleep apnea, they're all complaining about their CPAP. Their mask doesn't fit, the pressures are too high, the thing is leaking, and many of them, will cite the nose. So a number of different studies will say that isolated nasal surgery can help with CPAP pressures and tolerance. So there's a meta-analysis out there, I'm going to go right to it, that looked at isolated nasal surgery and CPAP. So in 279 patients, 18 studies, they had various nasal procedures. You all are experts on what those are, septoplasty, turbinate reduction. And in those patients, there was a decrease in CPAP pressures of about 2.5 centimeters of water. A nice improvement, a really nice improvement. Now, here's the kicker. Remember, this is a selected group of patients that complained about their nose. So after nasal surgery, we went from 39% being regular CPAP users to 92% being regular CPAP users. And there's also a nice increase in the duration of usage. So again, I may say to my patient, hey, I can work on your nose, but don't do it to fix the sleep apnea, but it may help you with CPAP tolerance, getting the pressures down and usage. One other quick thing is, in patients that have septoplasty or turbinate reduction that I do, I will actually put them on CPAP the night of the surgery, right? Because remember, they have airway issues. I don't give them narcotics, and I have them use their CPAP the night of the surgery, usually a full face mask. And I don't want to put somebody to sleep that's got really severe apnea. Okay, so I think we're doing pretty well here on time. So, few conclusions. One, obstructive sleep apnea is an airway issue. You and we are airway experts, right? We should intimately be involved. There are likely multiple levels of obstruction, and don't forget the narrowest part of the airway, the nose. Every patient's different. It's not, you just don't come in and say, yep, I want the surgery for sleep apnea. We're going to assess the airway and decide what's most appropriate for you, if anything. And I got to tell you, we turn away a lot of people because, we want to help you, but we don't want to hurt you. We approach the airway in a thoughtful way and with respect. Be very careful with multi-level surgery. It's dangerous, particularly in our sicker, heavy population. Remember that sleep apnea is probably not your only patient's sleep issue. We all have many of them, be it insufficient sleep or insomnia or musculoskeletal issues, medication side effect, caffeine use. There are a lot of issues that affect all of our sleep. And the key to surgical success is really anatomically focused, and it's really all about patient selection. With that, I thank you. There's my email. If any of you would like to also, contact me or ask me questions about any of this stuff, I'd be more than happy to communicate with you about any of this. Obviously, I get kind of excited talking about it, so feel free to reach out. And as I mentioned at the outset, I really do enjoy working with the dental community, and I think we have a few minutes for questions as well, so I'll leave it at that.
Thank you very much, Dr. Siegel, for this wonderful lecture. So it's been very comprehensive and informative as always. So now we are going to proceed with the Q&A. And our first question is about DISE. So does the drug-induced sleep apnea behaves the same as the regular physiological sleep? So is the obstruction side the same? Do we have any data on that?
That's such an insightful question. So we are making, when we do drug-induced sleep endoscopy, we're making the assumption that pharmacologically induced sleep is what is actually occurring in that individual's sleep, and we do not have a study that confirms that. It's really hard to do a sleep study on or it's really hard to look at somebody's airway when they're truly asleep. Imagine, being asleep in a lab and having a scope in there looking around. It's really hard to do that study. So the short answer is no, we don't really have a great, we don't know for sure that they are accurate, and you can't not consider the potential impact of the medications. And the other thing, which is fascinating, which is if depending on how much y'all know about sleep, is it changes over the course of the night. Why at some points of the night am I having lots of apneas? Other parts of the night, really nothing. Like something is going on physiologically. Same person, same airway, but there could be certain parts of the night where I'm having frequent events, or they could be 10-second events. Later on in the night, I may be having 40-second events with big desaturation. So again, there's much more to the story, but that's still a step up from where we were, which is just that in-office, look in the mouth, Mueller maneuver, if you know what that is, upright, awake, with muscle tone examination. So yes, it's a really good point. And a lot of the studies that have been done will take like 5 different observers, give them the same dice and say, hey, what do you see? Grade this. And there's a whole grading system. And you'd be amazed at the range of outcomes that you may have depending on who's looking at that. So it's not perfect. It's better than where we were, but it's far from perfect.
Great. Thank you very much. So do you recommend an ENT consult for every patient who is interested in a sleep appliance to rule out other issues that may be causing apneas? Tricky one.
Yeah, that's a tricky one. I mean, I guess in an ideal world, it would be nice, but I don't think it's essential. I mean, experienced dental sleep medicine providers, if something doesn't seem right, if somebody has risk factors, if they're, overt anatomic issues that you think may not predict well for good outcomes, I don't think it's essential in every patient. It's certainly not essential in every patient. I think in an ideal world, sure, it'd be nice, to have someone check the airway, but I don't think it's essential. Dr. Schaefer, do you have thoughts on that?
No, I think, following the instruction you gave us in this lecture would help. I think you have to examine the nose and get and have that as part of your exam. And if you see something that's is suspect, then send it to ENT. I mean, I get a lot of referrals from ENT, so I think the evaluation has already been like that. But I do think from your lecture too, I think it underscores when patients don't respond well to oral appliance therapy, there's other things we can do, and maybe that's the time to send the patient to an ENT person to see if we're getting the right kind of care that can help the patient.
Agree.
Okay, so what are your thoughts on laser treatment on the palate?
Yeah. So there are a couple of companies right now that are out there targeting dentists for laser treatments. Now, I want to be very clear, this is nothing new. This has been around the ENT community for 35 years, and nobody does it. You don't see ENTs lasering, doing this sort of blanket laser of the palate, or doing big troughs, the old layup procedure, the laser-assisted uvulopalatoplasty. We're not doing it. I hope you've learned from my lecture that it's way more complicated than a superficial CO2 laser kind of painting of the soft palate. I think that there's probably, in very appropriately selected thin individuals where you're convinced it's palatal snoring, I think some of these laser treatments could probably help. But notice how I phrase that. In limited patients with thin palate, palatal snoring that don't have other suspected levels of obstruction, you may get some improvement. So how's that for a sort of a weak endorsement of it? I know that it's being pushed to dentists. And again, this is what we do all day, every day. We mess with the palate. There have been laser therapies that have been around in our field, and you won't find an otolaryngologist that uses laser treatment of the palate.
So I'll ask a question. Noah, when you send a patient for dental appliance therapy, have you already done a drug-induced endoscopy that shows you that is indicated?
No, that's a cool question. So the short answer is probably not. I think it's fair to say that there's a subset of patients that tend to do better with oral appliance therapy, and those that are on the thinner side that have mild or moderate sleep apnea, that have good dentition, that don't have really bad sort of joint issues, that maybe perhaps have a palatal component and good nasal airway patency. So, all of those things together, I'm pretty comfortable in sending. And the other thing that I do, and that is part of the exam. Granted, it's a little bit different than what I mentioned in my lecture, but when I have the scope in their airway, I'll have them just do a jaw thrust. And when you do that in every single patient, you see some people that respond very robustly, and you see their vallecula open up and the jaw move forward and everything kind of splay open right out in front of you. Those are people where I'm more confident in doing that. If you're really not quite sure, about what's going on with the airway, a drug-induced sleep endoscopy is a good thing to do. Yes, while the person's asleep, you can kind of do a jaw thrust and look to see what happens with the airway. But we all know pretty much everyone's going to make the airway better, right? That's kind of basic, airway management, right? So the short answer is no, not really. But in an ideal world, it's not unreasonable. And in the majority of time, people, they just want to kind of get moving also with their therapy. So a lot of times I'll just kind of move them along and kind of skip doing drug-induced sleep endoscopy in that scenario.
Good.
Go ahead, Dr. Sheehan.
Oh, I was just going to say, when you do your drug-induced endoscopy, I guess that's a separate procedure. You would do an initial exam and then do the DICE at the second visit, or would you do it at an initial visit?
No, so they would come in, then it goes through the whole surgical scheduling thing. So, do insurance authorization, get time in the operating room. So they'll actually go to the operating room under anesthesia with an anesthesiologist monitored.
Okay.
So that can delay things quite significantly.
Good. A question that asks about Inspire. Do you see side effects from people with Inspire that might have dental side effects, like with the tongue thrusting, causing changes in position of their anterior teeth?
Yeah, I really haven't heard that. Really haven't heard that. I don't know if you've come across that, but I'm not necessarily convinced that there's enough kind of sustained force to sort of result in dental changes. I haven't come across it. So the short answer is no, I really have not.
No, I haven't either. It's an interesting question, but I don't think we've seen enough Inspire patients really to make an answer on that.
Agreed.
So, what are your thoughts on taping the mouth during sleep?
Yeah. So I get asked this by a lot of patients every day. So if you recall in the lecture, I think that in many people, you can improve airflow resistance. And probably what's happening is with your mouth stabilized, you change airflow dynamics with your mouth closed, you stabilize the airway to some extent. So you improve airflow dynamics through doing that. I think it can be hard for people if they have some sort of anatomic issue with their nose or chronic allergies to just tape the mouth, right? If the hole isn't big enough, taping the mouth is just going to exacerbate symptoms. I do believe, however, it can be something that individuals can be trained on. I don't think it's inherently dangerous. I know that there have been some reports about how it's dangerous to tape the mouth at night. I really don't have any issues in trying it. And there's certainly a lot of people that tape their mouth every night. I don't think it's dangerous. If they snore less and they sleep better, I'm fine with it. I do think that before in an ideal world, it wouldn't be bad to have somebody get an intranasal examination to see if there's anatomic issues there, or inflammatory issues, which may be contributing to this person's chronic mouth breathing. But I think it's probably just fine. But that comes up a lot.
This is a good question from Dr. Mintz. Made some statements about the CHAT study, talking about watchful waiting for 7 months after when you're deciding to do a tonsillectomy or adenoectomy in children. That many of this, 47% of the children are normalized. So that brings up the question: is at what age do you decide that an adolescent needs a tonsillectomy or an adenoectomy?
Oh boy, that's a really insightful question, and a really tough one. I don't think there's a clear answer to that. I think it's, every kid is an individual, and you take them in a full clinical context. Are they doing well in school? Are they wetting their bed at night? Are they obese? What is the severity of their sleep apnea? Is it a borderline case, or are they super severe? I think, each case needs to be individually assessed, and there's no right or wrong to that. I can tell you, if I'm a parent and my kid is 12 and they're wetting their bed and they're falling behind in school and they're not breathing well, I'm not waiting. Even if, I'm not waiting, I don't want to wait a day if I think this can potentially help the kid, versus, your sonorous kid that's got a mildly positive apnea that's doing fine in life, and then everything in between. So short answer is, I don't think there's a cutoff, and you need to sort of assess each kid individually.
And for an adult, the risk factor of bleeding and things like that, you hear some horror stories. What is the percentage of that, and how big a risk is that? I mean, obviously, doing a tonsillectomy, someone like that can make a world of difference in their sleep quality and their life.
Adult tonsillectomies suck. They're horrible. The pain is substantial. They all need narcotics. They get dehydrated. The risk of bleeding is real. In kids, the risk of bleeding is probably 2 to 5%. I think in adults, it's 10 to 15%. And why that is, I don't have a great answer for it, but we see it way more in adults. Their pain requirements are much higher. Certainly, there's good long-term outcome both for inflammatory and obstructive indications, but don't underestimate that recovery. It's a big deal. The recovery is miserable. Having said that, the vast majority of people that have gone through it are glad they did it, but in the short term, it's very significant. It's really significant. And, once you get to a certain age, if you've got cardiac comorbidities, or any kind of bleeding tendency, really high threshold to recommend a tonsillectomy.
Right. Great answer. So Dr. Shafiq asked a question about vasomotor rhinitis and whether turbinate reduction will help with nasal breathing at night on someone like that.
Yeah. So for those of you that don't know what vasomotor rhinitis is, the hallmarks of vasomotor rhinitis are clear, watery nasal drainage, usually bilaterally, that classically occurs in response to temperature changes, eating, spicy foods. We see it much more in an older population. And our primary medical therapy is, and it has to do with kind of an imbalance between the sympathetics and the parasympathetics. And our primary medical therapy is using ipratropium bromide, either 0.03 or 0.06% sprayed nasally. Usually that's pretty effective. In refractory patients, messing with the turbinates can help. It can help. Is it going to fix it? No. I wouldn't do a turbinate reduction if somebody's only complaint was vasomotor rhinitis. Probably medical therapy. If they also have nasal obstruction and prominent inferior turbinates, we may get 2 birds with 1 stone. But I don't think I would do it. I don't think I would do a radiofrequency or any kind of turbinate reduction specifically for vasomotor rhinitis. Having said that, there are some newer devices that are on the market. One called Clarifex and one called Rynair that treat the posterior nasal nerve, the sphenopalatine ganglion area. And that can help with vasomotor rhinitis. So there are some procedures that we didn't really talk about today that can help with that as well.
Yeah, thank you. I've got pretty much one more question here, and Maria, help me if there are other questions that I might have missed. And this asks about doing a second septoplasty or terminectomy after, a number of years. Is that something that's indicated?
Yeah. So revision septoplasties are tricky because, as you know, before you've manipulated tissue, you've got nice planes between the cartilage and the perichondrium, or the periosteum and the mucosa within the nose. Revision septoplasties are definitely tricky. Oftentimes, we refer those to our facial plastics colleagues that kind of have to open and reconstruct the nose. Turbinate reductions, yes, you can, but you just also have to be careful not to beat up the turbinates too much, because then the mucosa becomes non-functional. And what will happen is they may get a lot of dryness, scabbing, and crusting in the nose. So you have to be pretty conservative with that. Again, this empty nose syndrome gets a lot of press because it's kind of a name of a condition that people remember. It can really be bothersome to individuals that have it. So yes, those things are doable. Conservative with revision procedures, because they become difficult. You risk, potentially impacting the, support of the nose and leading to a higher risk of, chronic nasal crusting, which can be really annoying to individuals that get it.
Right. So that's 9:06 right now. So we've gone through most of the questions. Maria, correct me if I'm wrong, if there's anything we want to ask. But I've got a lot of positive feedback in the chat about your presentation. People really enjoyed it. Maria, did you have another question?
I do have one more question. Dr. Siegel, what are your thoughts on tongue tie and airway?
On what?
Airway.
Tongue tie. Fixed. So if someone has a tongue tie, is tongue tied.
Oh, tongue tie. Sorry. Boy, this is interesting. I thought we were going to get through a dental lecture without talking about tongue tie. So there's a lot of really confusing stuff being written right now about tongue tie and airway. There are some folks that will release tissue in the anterior floor of mouth, couple that with myofunctional therapy, and use that to treat airway. For the life of me and otolaryngologists, we can't understand how releasing tissue in the front of the mouth is going to somehow help the airway. I know it's being done, and I know the main person doing it is an otolaryngologist who gets a lot of publicity. This is not mainstream otolaryngology. I don't do it. The only folks that I know that are doing tongue tie releases for airway concerns are dentists. And if you ask just about any otolaryngologist about that approach, we have a really hard time understanding why that's going to help improve airway pain. See, if anything, to me, releasing, something that's tethering the tongue anteriorly is going to make the airway worse. Granted, there's probably a minor role for myofunctional therapy, which is essentially mouth and pharyngeal exercises to help perhaps, improve muscle stiffness over time. But even the data on that is kind of questionable. Do you have a comment on that, Dr. Schaefer, on tongue tie?
No, I'll go with your answer there. I think it was a great question and a great answer, and I think a good last question. I think it was really a great presentation. I'm so glad we asked you to lead off the series. It was really successful. Thank you very much. To everybody that's listening, you can get CE credit. We're going to send you a link in a couple of days to getting CE credit for today's presentation or tonight's presentation. And also the PDF of Dr. Siegel's lecture is going to be available. And we're also taping the lecture. So I assume that's going to be on our CE website eventually. So thanks again to Dr. Siegel, and we'll see you again.